Welcome to the Johns Hopkins Medicine online webinar series. Today, Johns Hopkins maternal fetal medicine specialist and director for Center for Fetal Therapy, Dr. Amit Bashat, will be speaking about management guidance of monochorionic twin pregnancies. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Bashat to begin our presentation.
Thank you, Amy, and thank you. And I'm looking forward, hopefully, to some questions today. I wanted to talk about management guidance for monochorionic twins and cover some of the issues that we find a lot of referring physicians are interested in hearing more about. So I have nothing to disclose, and my goals are basically to review the complications specific to monochorionic twins and the prenatal signs, and then also discuss the assessment and management strategies. So the first thing to understand is that there's a fundamental difference between a dichorionic and monochorionic placenta. If a twin pregnancy arises from two fertilized ova, you have a dizygotic twin pregnancy, which by default will have two placentas and two amniotic sacs. In a monozygotic pregnancy, the pregnancy that is conceived and results in a single zygote, the placental arrangement depends on the day of splitting post-fertilization. So anything that happens within the first few days after fertilization results in a dichorionic placentation that can be monozygotic. Anything after that results in monochorionic placentation. As a rule of thumb, the later the splitting is, the closer the twins are together. So anything that results in basically a twin pregnancy at the end of the first week, you have a single placenta with two amniotic cavities. The splitting towards the second week results in a monoamniotic twin pregnancies, and even later in conjoined twins. And these kind of forms of monochorionic placentation and twin and amniotic arrangement get successively rarer and rarer. Overall, monochorionic pregnancies are found in 1 in 250. Now, the complications that can arise in monochorionic twins are basically due to the placentation. The functional unit of a placenta is a cotyledon, where basically from the umbilical artery, the artery goes and dips into the placenta, and basically nutrient-poor blood and deoxygenated blood gets replenished and brought back to the same baby by a vein. In a monochorionic placenta, you have entities that are called the shared cotyledons, where basically the artery from one twin connects with a vein to the other twin. And these shared cotyledons, they're found in all monochorionic placentas, and they can exist in either direction. In addition to that, there are also unidirectional, bidirectional anastomosis between arteries and arteries or veins to veins. And the flow direction depends on the pressure on each side. So the normal monochorionic pregnancy has a set of unidirectional connections between the twins and bidirectional connections. So these connections can give rise to different forms of clinical pictures. So large artery to vein anastomoses typically have deep connections in a cotyledon, and they predispose to ultrafiltration of volume from one twin to the other. And What that results in is in hypovolemia in a donor baby and hypervolemia in a recipient twin. The clinical picture that is associated with that is very comparable to overhydration and dehydration. The principal findings in a donor are less bladder filling, whereas the recipient urinates more, has more bladder filling, and that ultimately results in decreased amniotic fluid volume in the donor and increased amniotic fluid volume in a recipient twin. And once the fluid is less than 2 centimeters in its maximum vertical pocket in one baby and more than 8 in the other, that then meets diagnostic criteria for twin-twin transfusion syndrome. When there are small artery to vein anastomosis, these connections are more direct and nearer the surface, and they predispose to unilateral red cell passage between one twin to the other. The clinical picture that arises from that is different from TTTS in that one baby loses red cells and becomes anemic, while the other baby becomes polycythemic. The clinical findings are different. So the anemic baby gets a hyperdynamic circulation with increased blood flow velocity, and we can measure increased flow velocities in the middle cerebral artery, which is sort of the vessel that we use for standardized assessment of risk for fetal anemia in pregnancies where those risks are to be found. And the polycythemic baby has decreased blood velocities. And so if these velocities change to a significant threshold above and below the multiple of the median for gestational age, then the diagnosis of TAPS is made. Now, if the connecting points between these shared cotyledons is not centrally on the placenta, then one baby has access to a smaller portion of the placenta. And the baby that has access to a smaller nutrient providing territory is at risk for being smaller. And when these size discordances meet a threshold of being over 25%, or one baby has a smaller estimated fetal weight than the 10th percentile, then this constitutes the diagnosis of selective fetal growth restriction, which is basically unequal nutrient sharing. And these babies are also at higher risk for placental dysfunction, which is best assessed by doing umbilical artery Doppler, where the clinical trajectory, and I'll come back to that, is significantly different, whether the blood flow in the cord is forward, absent, or reversed, or if it is variable. Finally, there's also the risk of acute hemodynamic compromise to large artery-to-artery anastomosis. If one twin experiences compromise and has a drop in blood pressure, these vessels allow for rapid exsanguination of one baby to the other, and they are sort of the primary pathways that are responsible for the higher rate of single twin, double twin demise, white matter injury, and neurologic deficits that are much more commonly seen in monochorionic pregnancies than in dichorionic pregnancies. And the clinical sign of these vessels is basically a variable umbilical artery blood flow pattern, which is due to fluctuations in the blood flow pulses from one baby to the other. And sometimes you can also image these anastomoses directly on the placenta. And these anastomoses are responsible for less predictable clinical behavior, co-twin exsanguination after demise, and brain damage in co-twin after single twin demises. So understanding the sort of vascular structure of the monochorionic placenta, it is exceedingly important that we are clear on that twin pregnancy is not actually a diagnosis. There's a fundamental difference between the risk profile of monochorionic and dichorionic twins, which is basically true all of the conditions that can exist in monochorionic but not dichorionic twins, that basically require us to approach monochorionic twins with a completely different focus in prenatal management. So the focus of monitoring a monochorionic multiples is, number one, determine the chorionicity. And once you know a pregnancy is monochorionic, then do monitoring for signs of unequal volume sharing, red cell sharing, nutrient sharing, or placental insufficiency. So the best time to assess chorionicity is actually in the first trimester. A dichorionic pregnancy will show, you can picture the amnion, but there is typically interposed chorionic tissue that extends often between the amniotic membranes between both babies. In contrast, in monochorionic twin, the amnion of both babies coalesces, is thinner, but seemingly inserts directly into the placenta. And most importantly, there is no intraamniotic chorionic extension. This kind of extension of the amniotic membranes directly into the placenta, or sort of the finding of the chorionic tissue in between, have been termed the lambda signs and the T signs. And they are very strongly sensitive for chorionicity in the first trimester. The other signs that can suggest a dichorionic pregnancy are discordant fetal sex, separate placentas, obviously, if the membrane thickness of the intertwin membranes is over 2 millimeters, if you can see more than 2 membrane layers. And it's important also to recognize that the lambda sign is lost with advancing gestational age. So when you look at the combined sensitivity to accurately reflect chorionicity, it's basically the lambda and the T signs in the first trimester cumulatively have a sensitivity and specificity of 98 and 99% respectively. So once you have determined the chorionicity, the surveillance pattern starts in the first trimester by labeling, doing a first trimester screening, and then basically doing a risk triage in the first trimester, and then in the early second trimester as well. It's also important to recognize that monochorionic twins have higher risks of CNS anomalies, cardiac anomalies, also abdominal and genitourinary anomalies. So the first trimester anatomy survey is important for patients that undergo nuchal screening because you can identify babies with discordant anomalies. The other thing that is also important is that the nuchal translucency screening, which was originally introduced for screening for Down syndrome, also serves as a marker to detect babies that are at higher risk for cardiac anomalies. So an elevated nuchal with a reverse ductus or significant tricuspid regurgitation is associated with significantly higher risk for cardiac disease to be present. And in our practice, these patients, we do actually perform first trimester fetal echocardiography and to look for major heart defects. The other things that are important is to look at the maximum fluid pockets and look if the fluid is concordant within 4 centimeters maximum vertical pocket, and if the crown rump length are concordant or discordant. A crown rump length discordance over 12 millimeters and fluid discordance is associated with significantly higher risk for adverse outcome and much lower survival than when the size is concordant. So, so that in the first trimester, you can already sort of make or lay down the management path about, how you want to evaluate these babies moving forward. The next most meaningful examination, unless there are some really overt abnormalities that you gotta consider management early on, is a 16-week scan, where you can look at the discordance in amniotic circumference, discordance in amniotic fluid, and look at where the cords are inserted. So basically, a larger discordance in the abdominal circumference between both twins, discordant fluid and discordant insertion of the cords in the placenta is also, again, associated with a much higher risk for adverse outcome. And these patients, in our practice, we typically scan weekly rather than every other week, which is sort of the baseline if everything is normal. So the monitoring pathway for monochorionic twins basically is the first trimester risk assessment, the early second trimester risk assessment based on a discordant sizes, and then basically, if you have concordant findings, you do your ultrasounds every 2 weeks. But if there's any discordances, then you need to increase the surveillance frequency to weekly. The background risk for cardiac defects requires that monochorionic twins do get a fetal echo as well. And the assessment that has to be looked at every 2 weeks really is the maximum fluid pockets, the umbilical artery Doppler, the middle cerebral artery Doppler, cervical length in the beginning of pregnancy, and basically any additional parameters if there are complications that are to be found. Now, the other thing that's important to recognize is that twin pregnancies can present with overlapping clinical pictures, right? So, and so not all patients fall into a single type of problem, because these vascular features that I mentioned earlier on the placenta, they can actually coexist in the same pregnancy. So looking at maximum fluid pockets gives you an inkling if there's volume discordance going on. Size discordance over 25% is typically associated with placental share problems, and there is a group of pregnancies where there is concurrent TTTS as well as sFGR. And then there's a group of pregnancies as well where there is also discordance in the MCA peak systolic velocities, particularly if there's coexisting fetal growth restriction. So if the predominant clinical picture is amniotic fluid discordance and the condition is TTTS, what should you do? So once you have TTTS, you basically assess the severity of the condition by the Quintero staging. Multiple staging systems have been described, but at the end of the day, the Quintero staging has actually stood the test of time. And what it looks at is the bladder filling, the umbilical artery Doppler, the ductus venosus Doppler, the umbilical vein, and the presence or absence of hydrops. As you have more critical Doppler abnormalities or as hydrops develops, basically the stages increase from stage 1, 2, 2 has no bladder filling, 3 has critical Doppler abnormalities, 4 with hydrops. But as this progression is observed, there is less likelihood for spontaneous resolution, and the overall mortality increases drastically. So the treatment for TTTS is an interruption of the vessel connections by fetoscopic laser surgery, which is indicated for stages 2 and above, but also offered in stages 1 when there are additional risk factors. Now, the technique of laser surgery has significantly evolved over the last 20 to 30 years. So the principle is that you go with a fetoscope into the sac of the recipient, identify the equator, and basically separate the vessel connections. When laser surgery was first described, the coagulation oriented itself along the vascular, not the vascular equator, but the membrane. That means what that did is it closed all the vessels that crossed the membrane, but it also closed vessels that actually didn't connect with the other baby and were important for nutrient supply actually to the donor. And this technique resulted in a cure rate for TTTS, but also had a high donor mortality in excess of 30%. The next recognition was that you can actually treat TTTS by just focusing the connecting vessels. So you can be selective with your laser surgery. So this kind of technique orients itself to where actually the vascular connections are, which is what the vascular equator is called. Now, but these laser surgery does not target the entire vascular equator, just the vessels that you visually identify. And although a cure is observed, there is also a higher risk of recurrent TTTS because there might be vessels in the areas in between that end up being bigger or enlarging once the main channels are closed. And so you have a recurrence risk for TTTS of up to 19% in some series. And in 2013, we described the Solomon laser technique, which basically orients itself along the equator, but also coagulates the vascular equator and thereby closes very small hairline vessels that may not be relevant, but that can open up later on and cause recurrent disease. And so the Solomon laser can convert the monochorionic placenta into one that functionally is like a dichorionic placenta. And that's ultimately the goal of the laser surgery. So earlier this year, we published our outcomes in stage-based survival doing Solomon laser in almost 450 pregnancies. And what we basically see is that the overall survival for recipients is 87%, overall 80% for donors, and 75% double twin survival. When you compare this to the literature for selective laser, the survival rates for the individual categories are somewhere between 4 to 17% higher. So for us, the Solomon laser technique has become the first-line treatment for TTTS, because even if you don't have a surviving co-twin, like in stages 3, where you have a higher incidence of selective growth restriction, because the laser is complete in over 95% of cases, the surviving co-twin is actually protected from the risks that can happen from sudden reversed perfusion. So that's our first-line therapy, particularly for parents that seek double survival. Now, when the predominant clinical picture is size discordance and these criteria are met, then you have the diagnosis of sFGR. Now, in the assessment of monochorionic twin pregnancies, there's a difference in the percentiles by using twin versus singleton growth curves. Several reporting softwares in use allow you to actually select twin growth curves, and they're particularly helpful in identifying growth restriction that happens in the 3rd trimester. Now, once you get these size discordances, there is an important difference in the clinical behavior based on the umbilical artery Doppler. So babies that have steadily forward flow in the umbilical cord present like late onset singleton growth restriction. The clinical progression is relatively slow. The complications rates are also relatively low. The progression is predictable, and so you can adjust your monitoring frequencies. The average gestational age at delivery is at 35 weeks, and there's a relatively low rate of brain damage in FDIU. When you have absent or reverse end diastolic velocity, this is sort of a more severe onset, early onset of growth restriction, but it still has a predictable progression. In contrast, when you have variable end diastolic velocity in the umbilical artery, this means that there's a hemodynamically significant artery-to-artery anastomosis. And these pregnancies are characterized by variable and unpredictable progression with a high risk of unanticipated stillbirth and brain damage in the co-twin. So the management options for selective growth restriction are basically expectant management, traditional laser surgery, or selective reduction of the compromised twin by cord occlusion. A large meta-analysis sort of compared the outcomes with these 3 strategies, and basically these are summarized in these tables and basically show that the higher or the more abnormal the umbilical artery Doppler, and particularly when you get type 3 sFGR, there's an increasing rate of compromise in the twins with expectant management. And when you look at laser and selective reduction of these pregnancies, it has a higher mortality because obviously when you do a selective reduction, the co-twin always passes away. And in the laser, the co-twin mortality can be 50 to 60%, but the morbidities are reduced. And that's why many parents, particularly if this kind of type 3 or type 2 IUGR is established early on in pregnancy, will consider the option of selective twin reduction. Now, if your main issue is MCA discordance, then you make the diagnosis of TAPS. TAPS is a condition that happens through small vessel connections if it is spontaneous TAPS, and it presents with the signs of fetal anemia and some other associated features. So you can have discordant echogenicities in the placenta, you can have a starry sky liver appearance in the polycythemic recipient twin, and fetal growth restriction 40% of these babies. Importantly, a significant amount of these patients have completely normal amniotic fluid volume. So if you didn't do MCA Dopplers, you wouldn't actually know that this is going on. Now, the staging that exists for TAPS is unfortunately confusing because it has evolved over time. So the most liberal one is the more recent Tolinar staging that says like, well, once your MCA PSV is discordant over 0.5 MOMs, then you can call it TAPS. The most restrictive is the recent Delphi consensus, which basically says like the discordance has to be at least 1 MOM, and one baby has to have clear signs of anemia, while the other one has to have clear signs of polycythemia. The higher stages are basically allocated using the same parameters that we use for Quintero staging. There are different management options for TAPS. There's expectant management with monitoring because the disease can be slow to progress, and the anticipated latency to delivery is about 7 weeks. The longest latency to delivery is for patients that undergo selective reduction or laser surgery, which is feasible in those cases where you can actually see the vascular equator, and serial intrauterine transfusions and exchange transfusions in one baby have the lowest latency to delivery of about 4 weeks. The consideration which treatment is the best one depends honestly on the severity of TAPS, at what gestational age the patient presents, and if there is access to the equator. Anytime you can access to the equator, we will try to do so. And if the gestational age is early, then it is unlikely to get to a meaningful gestational age with transfusions, and other treatments have to be considered. TAPS has significant risks in terms of hematologic abnormalities and transfusion and exchange transfusion needs in the NICU. There is a high rate of respiratory complications and a high rate of brain injury, both in post-laser and spontaneous TAPS. Now, the other thing I wanted to just sort of wrap up with is monitoring after interventions. Most of the patients that get prenatal interventions, they return to the referring physicians, and the goal is to deliver basically at home. But nonetheless, there are some important things to look out for. So complications that can arise from the surgery is membrane separation that can become progressive and eventually present with a fluid leak or overt PPROM. Intertwin membrane damage can lead to, can be visible very early on by a redundant membrane, and then can progress by intertwin membrane leaking of amniotic fluid. So here you see the membrane of baby B, baby A, and then there's a layer of fluid in between, and it can progress all the way to functional monoamnionicity, where the babies actually break through the membrane from a small little septostomy and end up in the same sac. So overall, the incidence of septostomy is somewhere around 10%. Functional monoamnionicity, we get in about 5% of post-laser patients. And the rate of PPROM is somewhere between 23 to 27%, by the time of delivery. Immediate PPROM within 2 weeks of laser is really only 3%, but these other membrane things can be progressive. The other thing is that there is a significant portion of patients that might experience cervical shortening, and about 10 to 12% of our patients do get post-intervention treatment for short cervix, either by placement of a pessary cervical cerclage or progesterone administration. That is more likely in those patients that present with a cervical length less than 3 centimeters before the laser. The fetal monitoring is important because you will typically see resolution of whatever disease like TTTS within 2 weeks of the laser. Obviously, when you do a single twin reduction, you continue monitoring in singleton, but you still want to know, is the placental function normal? Is there any evidence of placental hypoxia? So you look at MCA brain sparing, but also the peak systolic velocity, especially that's the only way you can detect post-laser taps. About 10 to 15% have cardiac impacts from the conditions that I mentioned about that might take 5 to 6 weeks to resolve, and they will benefit from cardiac Doppler as well. And sometimes also may have to deliver in a place where they have access to peds cardiology after delivery. Important to continue monitoring amniotic fluid pockets and start NST BPP monitoring typically at 32 weeks gestation. Although babies with pre-existing conditions have higher neonatal mortality and morbidity, the developmental delay is significantly improved once you deliver beyond 30 weeks, as is the rate for cerebral palsy. In monochorionic twins that are untreated, you still have to manage based on the baby that is the sicker one, because if there's open vessel anastomosis between the babies and that baby is at twin demise from a condition, then it can damage the co-twin. The situation, of course, is different in babies that have undergone treatment, particularly if there's clear evidence of resolving disease, or those that continue as singletons. Now, when you have monochorionic twin pregnancies with continuing discordance, typically the benefit of delivery outweighs the risks of ongoing monitoring somewhere around 34 weeks. And we will typically recommend that these pregnancies will be delivered by 35 weeks gestation. If you have concordance in size, Dopplers, fluid, and MCAs, those uncomplicated monochorionic twins can deliver at 37 weeks gestation. The other Doppler findings require consideration for progressively earlier delivery, particularly in babies where there are open connection between the two. A more individualized approach can be sort of chosen when you have patients that have been treated and obviously single twin survivors. So before I sort of come to the conclusions, I also wanted to highlight and invite, whoever is interested for our next webinar, which will basically highlight sort of the prenatal management, the fetal therapy aspects, the neonatal transition, and the postnatal management of congenital diaphragmatic hernia, which is scheduled on the 18th of February, and which will be presenting with our neonatology, pediatric surgery, and PICU colleagues that have also co-authored this manuscript that, if you are interested in, you're very welcome to look at. So in conclusion, the vascular architecture of the placenta predisposes monochorionic twins to very specific clinical pictures. Now, and because of that, the monitoring and the risk stratification needs to be prospectively planned out from the first trimester. And the prenatal diagnostic and staging criteria are now good enough to actually identify patients that may benefit from fetal therapy. And many of those can return to deliver at home and have actually a normal outcome. So with that, thank you very much for your attendance, and I'll be happy to look at some questions. Okay, so the question is, what is your approach to patient counseling for TTTS, and how do you involve other teams? And at what point do you engage maternal fetal medicine specialists, neonatal teams, or other pediatric specialties? So in terms of the approach, patient counseling with TTTS, so I think when we see a patient with TTTS, the one thing that we fundamentally will go over is to say like, well, what is the primary clinical picture? Is it straight TTTS? Is there something else going on concurrently? We will talk about the severity of TTTS. So where do they fall into the staging system? We will talk about the risks of TTTS as they pertain to sort of long-term developmental outcomes. And then we will talk about the risk and the benefits of the different treatment approaches. When you have TTTS, I mean, the management choices are you wait and don't do anything, you have laser surgery, you decide a selective reduction, or you decide pregnancy termination. And all of these options are actually reviewed with the parents. And the other thing that we do is, so we keep track of our outcomes real time. And so we will present our center specific outcome numbers to the patients just to sort of judge what is the risk of an intervention versus waiting, and what are the benefits of intervention. Now, in terms of involvement of other teams, the most common additional involvement really is if there's any cardiac problems, which can complicate about 10% of recipient twins. And here it is important to involve pediatric cardiology to sort of make a follow-up plan for after delivery. So that's sort of the most common. And then if we have patients that end up delivering here, that have issues with growth restriction where we anticipate earlier delivery, typically we will involve our NICU colleagues as well. The other circumstances where we might involve those colleagues or more recommend involvement if patients want to go back and deliver somewhere else and want to sort of say like, well, do you think it's okay for us to return? I usually encourage them to talk to referring providers to actually involve the local neonatologist and just say like, okay, given what is going on with my pregnancy, what can you tell me? Because at the end of the day, it is also the decision of the neonatology team there if all the care needs can be met in that particular NICU setting. What are the early indicators of worsening TTTS that would prompt more aggressive surveillance or intervention? So typically it is, once you have no more bladder filling in the donor, that's stage 2 TTTS. Under those circumstances, we would offer intervention. If the donor still has bladder filling, then we offer intervention if the patient has rapidly progressing polyhydramnios, cervical shortening, or is just uncomfortable from the polyhydramnios. If a patient elects to continue monitoring beyond stage 2, I think the next thing would be the critical Doppler findings. There are a couple of other nuances that are important. So early interventions before 18 weeks have a higher PPROM rate. So it's basically 10% in the context of the laser surgery versus 3% if you do it afterwards. So sometimes there's a benefit of waiting just to minimize the PPROM risks. And the other thing is that the success of laser surgery rests on visual access to the equator. So sometimes if the entry into the uterus isn't there, you may actually wait for polyhydramnios to come up a little bit higher. Now, in terms of the following, anytime you have a diagnosis of TTTS and you don't want to intervene, our practice is typically to monitor them twice weekly, just to provide a safety net that we capture, um, capture progression. Has there been research into using antihypertensive or anti-inflammatories? There was a presentation from a Brazilian group about 20 years ago that I heard that treated TTTS with indomethacin. And the thought was that indomethacin would reduce the urine output of the recipient twin, and they had significant pregnancy prolongation. Unfortunately, I never seen that in print, and it didn't imply quintero staging, right? So that's what I know about that. Now, how might genomic profiling of monochorionic twins improve risk stratification? So the monochorionic placentation really isn't a genetic disorder. I think where genetic testing of the babies at the time of laser surgery is beneficial is when you see some physical abnormalities that could be associated with monochorionic twinning, or could be just an expression of, aneuploidy or single gene defects. And in that setting, we would typically use the fluid and do genetic testing at that time as well. It is also possible to get discordant genetics in monochorionic twins. Now, there is obviously a reason why some monochorionic recipients or donors have disproportionate cardiac issues with the volume issues. And it's possible that some of that is, genomically predetermined by the forms of how, the cardiac contractile proteins are expressed and all that. And so I think that warrants some further study, but at the moment, there is no clinical benefit of that. And so the last question, how frequently do you perform ultrasound surveillance in monochorionic pregnancies? So every other week with all the Dopplers, fluid and size, if everything is even, and weekly if anything is discordant. Discordant umbilical cord Dopplers, discordant MCAs, discordant size, discordant fluid. That is a weekly assessment. If patients meet criteria for intervention, then obviously that needs to be considered. And if they meet criteria for intervention for whatever reason you want to monitor them on, that's typically twice weekly, I would say. And the monitoring can be done by the referring providers. And in many cases, we actually do either alternate or the patients return to a referring provider until they meet, a preset set, threshold where you're like, okay, now you got to come back for either further questions or interventions. All right, so I think we reached the end of the webinar, and that was the last question. I hope this was of interest to you. I look forward to seeing, as many as possible at our next webinar in February, and I hope everybody has a good day. Bye-bye.